First, Greg Ciottone. Greg is president of the World Association for Disaster, come on up, World Association for Disaster and Emergency Medicine, and a professor of emergency medicine at Harvard Medical School. Lorraine Giordano, who just by a historical note gave me my first real job in emergency medicine. So I blame her for everything I've done. Lorraine is the past president of the American Academy of Disaster Medicine and former medical director for the New York City Fire Department Bureau of EMS. Laura Iavicoli is the senior assistant vice president of emergency management at New York City Health and Hospitals, and I believe also at Elmhurst, if I'm not mistaken, clinically, correct? Okay. And last but not least, Larry Zacharies, who's the vice president of enterprise risk management and the chief security officer at Stony Brook University. So we'll start off with some questions. One of the things I like to say is that for this panel, as healthcare organizations, we operate in a very complex environment normally, under normal circumstances. So during a disaster or an emergency, it becomes even more challenging for us as healthcare systems and healthcare organizations to operate effectively at times. The world and the nation continues to experience man-made and natural disasters, which can exacerbate our fragile healthcare system. Globally, in September alone, there were numerous weather-related disasters, forest fires, earthquakes, erupting volcanoes, and a meningitis outbreak in the Democratic Republic of Congo. So we have all kinds of disasters. In New York City over the past 3 decades, we have had multiple rail disasters, 6 aircraft disasters, not including 911, multiple explosions, building collapses, hurricanes, tornadoes, and terrorism. Multiple explosions as well. And now we've had the pandemic for the last 18 or so months or more, with more people who have died from the pandemic, over 34,000 in New York City alone. So what's next? What is the next thing we should be prepared for? Are we prepared for everything, or are we not prepared at all? So I asked the panel, we'll just start here and work our way down. From your emergency medicine, emergency preparedness perspective, what do we need to think about from a global, national, and local perspective? Greg?
Sure, I'll start off. Well, thank you, and thank you also for having the panel, having myself down for this important conference. I think in the world of disaster medicine, it's sometimes easy to not fully understand the impact of disasters on healthcare systems and hospitals, and more focus on individual events. And I think this last almost 2 years now has really demonstrated the impact that disasters such as the COVID pandemic can have on all of us in the hospitals and the healthcare systems, both a direct personnel and patient care impact, as well as a financial impact, which we all experienced. We wish we could have a crystal ball and say this is the next disaster that's going to come down the pike. If you actually look at some of the financial numbers, the loss, and I think 2020 was about $300-something billion in healthcare hospital loss, whereas the preparedness money put in by the Assistant Secretary for Preparedness and Response, ASPR, was a fraction of that. It was something around 200-something million for hospital preparedness. So, had we known, I think in 2018-19 that COVID was coming, we probably would have put a lot more effort into preparedness, right? So this is sort of where we work in disaster medicine, trying to get over that period of sort of complacency where when things are going well, we don't think much about disaster, and when they strike, they strike. So Dr. Marshall talked about, are we prepared for everything? I would argue this idea of all hazard preparedness probably is not something that we should be thinking about. Nobody can be prepared for everything, nor should you be. And that's why we do things like conducting hazard vulnerability analyses, where we develop a relative risk profile based on historical precedent, as well as just common sense of not only what are the more likely disasters to happen, but how well prepared are we? And the output from such an exercise that gives us this relative risk profile. And if you're able to work your way down from the top of the list and enhancing your preparedness, I think you're doing a pretty good job. So, as sort of an introduction to this panel, I would, just finish this one question by saying, we have to get past that idea of complacency and realize that, of the disaster cycle, which involves mitigation, preparedness, response, and recovery, a lot of the attention is on response, but really most of the work that we do is in mitigation and preparedness, as well as recovery, learning the lessons learned.
Thank you. I just want to, before we pass it on, if you just give a little bit about your background,
Sure.
and then as we go down, you can give your background as well.
Sure. So I'm an emergency physician by training. I practiced about 25 years or so in the emergency department, primarily up in Massachusetts. I'm not going to touch the Red Sox-Yankees thing, I promise you. But my area of expertise sort of migrated early on in my career into disaster medicine, and now something that we are, a new initiative we are creating and pushing called counterterrorism medicine. And I've had a number of different experiences. I was a level 1 DMAT, or Disaster Medical Assistance Team commander. This is part of the Federal National Disaster Medical System. Back in the 90s and early 2000s, in fact, my team was one of the first federal disaster teams that came into Ground Zero on 9/11 when we spent 2 weeks there. I took some of the background and experience I had and created, or looked at disaster medicine as it was then, and realized that we need to maybe put some more meat on this bone and try to better define what the knowledge base and skill set should be around disaster medicine. So I came up with the idea of a textbook and published my first textbook in disaster medicine in 2006. Second edition came out in 2016, and with a little more effort, the third edition will be out in a year or so. So that's my background. I'm essentially a subject matter expert in disaster medicine and counterterrorism medicine.
I've been doing emergency medicine for approximately 50 years in all types of settings, military, urban, rural, suburban. Have a fellowship from the American Academy of Disaster Medicine, ACEP, and the New York Academy of Medicine. One of the best jobs I ever had was the medical director of EMS for the entire city of New York, at the time when there was one medical director running the entire system. We went from approximately 2,000 calls a day. We are now doing around 5,000 calls a day. And although I retired from the clinical aspect of it, I still maintain teaching and also an online medical control physician at the Fire Department Medical Control Center, which will be moving soon from Baspeth rather, up to the Bronx. So this should be interesting. I think a couple of things that I would like to say about where we go is never say you've seen it all. Every time, we did the first World Trade Center with the disaster, and then came the boat people, and then came the planes falling out of the sky, and then obviously the second World Trade Center event. And I think that's one of the mistakes that we can make. And the other is, from lessons learned, the important thing, I can go back to every analysis of every mass casualty incident, and at EMS and Fire Department, we're doing over 1,000 a year, and the same two things come out. One is the importance of communications, which always becomes an issue, and second, the fact of practice, learned, have drills, and then evaluate what you're doing and see what you need to change. Certainly, all aspects need to be looked at. So many common problems that occur. Yes, your disaster planning, but we had for the first World Trade Center, our command center was supposed to be right next to where the bomb went off in the truck. So you have to build in flexibility as well, and you have to think about, you'll be able to think on your feet and plan and move about accordingly.
I'm Laura Ivacoli. I am an associate professor at the Icahn School of Medicine at Mount Sinai, but I've been working clinically for about over 20 years at Elmhurst Hospital, which is one of the New York City Health and Hospitals. We're at a level 1 trauma center, and everybody probably knows it at this point as the epicenter of COVID. So I've been emergency management for about 20 years. I was the emergency management clinical director at Elmhurst Hospital for about 20 years. During COVID, I helped to coordinate the response at Elmhurst, as well as the system response kind of was born out of Elmhurst during Wave 1. And then I was moved to central office, and I am now the Senior Assistant Vice President for Emergency Management for New York City Health and Hospitals. In terms of the question of, are we prepared? I mean, I think I would just say with every disaster, there's things that, of course, went well, and then there's the things that could have been done better. And I think a lot has come out of the past year and a half with this most recent prolonged disaster response of the pandemic. And I think one of the big things that a light was shined on was that we really need to work together. We need to work together in our system, between facilities. We need to work together between systems, between regions, between states, and even globally around the world. And it was really highlighted that we need to break down these silos. We need to really coordinate between systems, between regions, be able to share patients, staff, resources, have greater economies of expertise in clinical care, and pool all of these expertise in clinical care, and don't have them so siloed. I would also say that we need to be able to communicate better. We need to be able to share data better, mitigate misinformation, disinformation, lack of user-friendly information. So data sharing systems, and just an overall integrated healthcare system. In order to have that, I think there probably needs to be a centralized citywide command center to make that happen. That would be the overarching entity that would coordinate something like that. I mean, the biggest barrier, of course, in everything that we do is money. And everybody has a bottom line, and they need to, meet their quotas, and that's understandable, and everybody has to make sure that they're, paying the bills and keeping the lights on. So I think having a centralized command center that could help coordinate such an effort, and taking it out of, the individual facility or systems, everyday operations, it would make it run much smoother. So those are my thoughts.
Thank you. Larry?
Yeah, good morning. I'm Larry Zacharies. I got started in the business really in just about 30 years or so ago, starting in EMS as a paramedic, and then making my way along a very twisting, winding road into law enforcement, into education. Went to law school along the way, did some bioterrorism work and some consulting work. All roads for me sort of started and ended at Stony Brook University. I kind of started and left and came back most recently about 12 years ago as the Director of Emergency Management, and most recently as the Vice President of Enterprise Risk Management, which is a structural change, and that's something actually that I'll speak to, COVID lessons learned. But to the original question, I think the number 1 and 2 threats that are facing us, and as was stated, I'm not a real big fan of all hazards planning. I think it's somewhat of a hackneyed term that has really evolved over the time. I'm more of from the school of continued operational readiness and resiliency is more of a culture than it is for we should plan for every possible contingency, which is really, it's really not possible. But the number 1 and 2 threats that we're facing in the healthcare sector, in the corporate world, really in every sector, is number 1 is the cyber threat, and number 2 is the supply chain. And I think we're seeing that play out now, certainly as a result of COVID and related to COVID. But I think we need to take those lessons and open up our aperture a bit and just see how, what I'll call the downstream effects of those 2 things, and they intersect as well. Our cyber resiliency as a nation is not nearly where it should be. And our cyber resiliency within our organizations is weak. It's certainly much better than it was just a few years ago, but if we queried the audience and I asked, if you knew who your Chief Information Security Officer was, or if you even had one, I know the hands would certainly not be unanimous. So those are the two areas where I think we have a lot of work to do.
Oh, thank you. All right. So this question I'm going to direct to Laura and Larry. You both mentioned some of the things that we need to think about when we're doing planning. And so what are some of the risks that we face here in New York City and New York State at the local level that we need to think about? Either you
go
or
first,
either
or-
one.
Go right ahead.
I wasn't sure who was I. I think, you have to kind of put it into, I think the easiest way to think about it is to put it into buckets. So, there's your natural disasters, there's your technological disasters, there's your human events. So, the natural disasters, obviously, that would be like your infectious diseases, what we're going through now, other things that we're going through now, all the weather things that we've been, experiencing, the winter storm, the heat, the flooding, the hurricanes, the wildfires out west, the volcanoes erupting, the droughts, all of that. The technological events, disruption in transportation, the big things like bridges going down, planes going down, fuel, not having fuel to be able to get from one place to another. I would say communication is very big in the technological sector, cyber, which was already mentioned, supply issues, critical equipment, and in supplies, staffing as well. And then there's all the human events that, we have to plan for. The civil unrest, the labor, the CBRN events, so your chem, your bio, your rad, your nuke, your explosive events that humans could potentially enact upon us. Your mass casualty incidents, your evacuations. So I think it's countless, but I think those are the three buckets that you would put them into: natural, technological, and human.
Yeah, and I'll pick up right where you left off and go back to some of your first statements. I agree with that wholeheartedly, and I think one thing that is critical to bridge between those buckets are the relationships. And while you can have siloed planning as it relates to the functional aspects of responding to those things, I think having networks, there's an old saying, if you're meeting your partners over the hood of the car in front of the building when it's on fire, then you've failed. And all of those networks should be well established. And being able to pick up the phone and having relationships, and even we were sort of joking before in the room beforehand, a lot of our paths have crossed over the last several decades, and those relationships and those networks are so important in the context of preparedness real time, but in the context of preparedness ahead of the event, and being able to have formal and informal relationships and training and sharing information ahead of time. It's the knee-jerk reaction that I'm not a fan of, and I'll go back to what I said before about resiliency and looking at our response from an enterprise level and thinking about all of those potential outcomes, but not necessarily responding to all of them, because that's into the minutia, and then we wind up going down a road where we're spending resources, excessive resources for the 1 or 2% likelihood of the event, where we could be spending much more for those things that are much more prevalent.
Thank you. Thank you both. So, Lorraine, you mentioned communication, and you served as medical director for the largest EMS system in the country, if not the world. And you had to deal with working with many health systems through those years. So what do you see as our challenges in working with systems? And anybody can pick up, but Lorraine?
I think the fact that people need to get together ahead of time, look out into your communities to see what groups are there that you can partner with, as well as what your local, regional, state, federal resources are, know about them ahead of time. To think about the credentialing, perhaps, of who will be working during the emergency, that they have been pre-credentialed ahead of time. that you work together in terms of plan development, that you practice together. Taking, for example, a tabletop and then bringing into it all of the people from all the different levels of care providers, organizations that you may potentially need. It doesn't help you if you have to evacuate your facility and everyone is using the same ambulance company. Those types of things. How are you going to get your gasoline to run your generators? Know that ahead of time. Who are you going to be contacts at the health department, the CDC, the state, federal? It all needs to be worked out ahead of time as much as possible. And as we said, many of our paths have crossed over the last 30, 40 years here, and in different roles. And it helps to have that camaraderie for everybody to work together in a time of crisis.
Yeah, thanks. And Greg, your role on a more global scale in a different city, what is your perspective?
Well, if I could just maybe address this last point real quickly too. I don't think there's any better example of how the need for systems and breaking down silos than this last COVID experience. I mean, everyone here is a healthcare executive, a healthcare leader. Think about that time in COVID, went from onset to when we actually had effective vaccine and maybe effective therapeutics, which are not quite there yet. But that period of time between those 2 points is all we have to depend on are non-pharmaceutical interventions, right? NPIs like mask wearing, social distancing, all the stuff that we've been doing. And that directly affects and affected the surge of patients in our hospitals. So there's no better, I think, example of when a hospital should sort of be in a medical system and a healthcare system should be sort of that beacon, that light on the hill, really promoting community involvement, helping the community understand why these non-pharmaceutical interventions are so crucially important. They were important in 1918, that's pretty much all they had, and they were important today as well. And just being that public education voice to try to get the community to help the community save itself is actually going to benefit the healthcare systems as well. So that is, I think, a prime example of breaking down silos and systems working together. The global level, so I'm the president of the World Association for Disaster and Emergency Medicine. It's the oldest international organization in this field. It was started in 1976. So I've had a glimpse of what this kind of global experience looks like for at least COVID and other things that have happened. And I would argue that, and you've heard this before with how we can travel across the world in 12 hours and how we can, borders are porous, et cetera. But it really is true, not just for the pandemic, not just for pandemics in the future, but also, when an earthquake can cause a tsunami that can cause a partial meltdown of a nuclear power plant in Japan, and then we can detect radiation on the west coast of America, or when a first dirty bomb in the history of the world, accidental Chernobyl, explodes, and it can cause further stochastic effects 3 or 4 countries away from the fallout and the radiation, we have to understand that, there are geopolitical borders, no question. I'm not naive about that. And we always have, issues and sometimes wars and different things we have to work out. But as far as a community global public health, we are like fish in a fish tank. And when one of your fish in a fish tank gets sick, if you don't remove and isolate that fish, the rest of them are getting sick, right? So we need to transcend these geopolitical borders on the global level so that we can do things like for pandemics, nip that outbreak, that first few sort of index cases of a new disease, nip it in the bud by early containment while we figure it out, and make it so that next novel virus that may be the nightmare scenario, God forbid, isn't allowed to escape to become an epidemic or pandemic. The nightmare scenario is, COVID has, for different age groups, but about a 1% case fatality rate, and its R0 value or level of contagiousness hovers somewhere between 2 and 3 plus. The Delta variant now is higher than that, it's more contagious. But the nightmare scenario is not that we have a case fatality rate of 1% or an R0 or contagious level of that, but instead the level of contagiousness or R0 level is that of measles or mumps, which is maybe 10 times plus more contagious than COVID. And the case fatality rate is not the 1% that COVID is, but it's instead maybe like what Ebola is, 50 to 70% but what rabies is approximates 100% case fatality rate. I would argue that not only with that virus, if it emerges and we don't control it early on and we don't learn how to do things like non-pharmaceutical interventions, would not only decimate our healthcare systems, would not only decimate our economy, but would threaten us as a species. So it's really time to learn the lessons that we just haven't been able to learn in the last umpteen years now, but certainly 100 years of pandemics that we've seen. We've had opportunities. 1918, 1957, 1968, the last SARS, MERS, et cetera. We've had opportunity to learn these. Let this be the last opportunity that we need to actually learn these lessons.
Well, thank you very much. That's great. Just to talk a little bit about healthcare systems as a target. So we build these wonderful, beautiful hospitals with glass fronts and, to make it very welcoming for our patients, because we want our patients to have a good experience and feel like they're walking into someplace special. But what are we doing to protect our facilities from terrorism, from an angry patient who drives a truck through the front glass wall of your facility? And anybody wants to jump in. Laura, you want to?
I mean, I think that's a really tough question. I think, of course, there's the mitigation equipment that, hospitals can put out front. I think some have, some haven't. I think we've come a long way from being so, which is a good thing, patient-centered and patient-focused, that we have come away from, putting up things like barriers and such, because they're not so patient-friendly. I think so we're starting to go back in that direction. I remember in the beginning of COVID, not so speaking to, events that could harm us physically, but just in terms of, barriers for staff to keep the virus, from the patients to the staff, and the struggle to get even those barriers put back up to keep our staff safe, because they weren't patient-friendly, and staff, on the front lines, not being able to wear masks because it wasn't patient-friendly. I mean, this is like way, way, way in the beginning. So, I think we're coming a long way. I think we have a long way to go. I think we also have a long way to go with messaging. Providing good, solid, evidence-based evidence that, these vaccines work, not, trying to, really shove them down people's throats, but really empower people with the information to make good choices and try to get away from politicizing, vaccines and masks, I think is a really important point too. I also think that, there is a point where, you can't cry fire in the middle of a packed, theater. One person's, ability to throw a punch, and it's their right, ends, right at the tip of the other person's nose. So, it does beg the question, if somebody who was afforded the vaccine and opted not to get it and infect somebody else, where is that liability in that? So I think it's a very muddy question, and I think, like I said, I just think we have a ways to go with protecting our staff and our healthcare workers on multiple fronts.
Great. Larry, you smiled when I mentioned the big glass front door. So
I did, only because we have a big glass front door in our hospital. And I just last week actually spoke at New York Presby's emergency management conference about an incident that we had in June of 2020, where an individual walked into our hospital with 3 improvised explosive devices into our emergency room. And the very quick story is that he was thwarted on his attempts to visit a family member, went out to a vehicle, put on what can only be described as was a tactical vest, complete with magazines with live ammunition, a simulated pistol, a mask, something out of a video game, and a backpack full of explosives, and walked into the emergency room. Luckily, it ended with him being taken into custody. Could have had a very different outcome. Still an ongoing criminal case, so I can't get into too much of the details, but when we talk about security or protecting the physical entity of a building or an institution, we tend to look at it in the layers of an onion, and the more layers you can add to protect that inner core, the sanctity of, in this case, the hospital itself, the emergency room, the better. So with this physical security, there are things to standoff distances and cameras and things like that. But there's also the culture within a healthcare organization, and not always, security is often very expensive. Not a lot of return on investment, not a lot of tangible metrics to go along with it until something happens. It's usually the first line item to go in a budget, value engineered out of new construction and capital projects. But if you invest in it, and I can speak from my experience at Stony Brook for sure, we've spent the better part of a decade building out a very robust enterprise-level physical security system. And it's directly related to the outcome that we had. It's not foolproof for sure, but it's the physical things we can do, and then it's establishing that culture and that awareness within the organization too.
If I could quickly comment and also put this into perspective, this is something we look at in counterterrorism medicine, and this gets to this complacency idea. When things are good, we sort of rest back on our laurels. But in the last 5 years, there have been several hundred primary attacks on healthcare facilities around the world. Now, historically, there's always been some attacks and intentional events, terrorist attacks. On healthcare, it's typically been a secondary attack. So there's been an event, responders go, and then they are attacked 5, 10, 15 minutes later, the secondary attack. We're now seeing part of the attack strategies being primary attack of healthcare, right? Which makes sense. If you're a bad guy and you're trying to think this thing through, if you try to decimate or attack healthcare as part of your attack strategy, obviously your capabilities and how you're able to care for the injured are going to be much less. So it's not something that's out there. It's something that's happening today. Has happened in literally hundreds of times over the last 5 years, and it's something that's going to come to our doors one way or the other, and we need to be prepared for it.
So we've had some conversation about COVID and the pandemic, and you've all mentioned different aspects of our preparation and response. And so a question about our response in terms of mass vaccination and mass testing. And in the beginning, we set up all these field hospitals and staffed them, and we had the hospital boat and all of those things. So from your perspective, your organization's or your own perspective, how did that work out? How was our response in those things? And what could we have done better in terms of our mass vaccination, testing, field hospital? Laura? Or Larry?
Yep, go, no, absolutely.
So I could speak from really all those perspectives. Stony Brook started off as really a parking lot emergency room surge space that was quickly realized by the county and the New York State Health Department as a great place for a testing site. So we got into the testing business pretty early. And as often is the case, a victim of your own successes, we then got into the mass vaccination business shortly thereafter, not one but 2 sites. And we were also chosen as a place for the construction of a 1,000-bed field hospital in the middle of our campus. So having all those things at the same time, some advantages certainly helped the local community for sure. We're north of 600,000 doses at the one mass vac site that's still open today. The second one has closed. But the ability for us to work with our local, I'll say, town, county, and state partners, and in many cases federal partners, both before, during, and after. So pre-construction, design, the planning phases, the actual implementation, staffing, logistics, all of that happening on a relatively decanted and not necessarily populated campus, but still an active campus that has residential housing for students and an active level 1 trauma center for the county. So all of those things, there was no plan, right? So back to the question before, can you plan for these things? There was no plan. Did we have a pod plan that was a push pod and a pull pod that we used during H1N1? Sure we did. Did it work for this? Absolutely not. The numbers were just overwhelming. The If you build it, they will come. In a pandemic, absolutely, especially when tests were scarce, and especially when the downstate resource was really stressed. So then having to do all those things simultaneously became an enormous challenge.
I mean, I would say, New York City Health and Hospitals stood up the test and trace program for the city and really did a phenomenal job. I mean, just mind-boggling what they did. I think that the mass vaccination sites did work. I think the modeling in the beginning showed that if you were going to vaccinate facets of the population who are most vulnerable and go down the list, that model worked as long as you didn't cause a bottleneck. And I think the city did pretty well, and Test and Trace did pretty well with, as soon as they saw the numbers starting to go down a little bit, they quickly went to the next group of eligible until they finally just opened it up in order to not create that bottleneck, because it was that bottleneck that would have really mitigated all of the benefits of these mass vaccination sites. So the second strategy, though, that they implemented that, is a tried and true strategy is, the ring vaccination that we've seen, with Ebola and other illnesses. So Test and Trace really got out there and, with the testing and the contact tracing, and then actually going door to door and getting, the ring of the person who was infected and then their contacts vaccinated, was another really successful, or has been another really successful strategy. In terms of the sites that they stood up for patients in the beginning in wave one, the military sites that were stood up, I think one thing that I would say that could have been done better is if they had paired the subject matter experts with the operational experts and really had them, the subject matter experts, inform the operational experts as to what was needed by the hospitals and what we could have benefited from, and then turned that into policy and created, these field hospitals that would have been better suited to our needs. I think that was the piece that was lacking, was that communication piece between the hospitals and the subject matter experts and the people on the ground that were actually setting these field hospitals up.
Lorraine, so in your experience, we talk about, Laura just mentioned subject matter experts and operational experts, and you've had a lot of experience trying to bring those two together over the years. And how has that worked in the past? And also, if you could talk a little bit about how EMS interacts with the field hospitals, because we've had several field hospital setups over the last 30 years. So how has that played out in terms of?
In terms of the actual ambulance services availability, we have approximately 450 ambulances out there on a daily basis, and these were utilized. There are regional groupings that interface with Jersey, with Long Island, with Connecticut, that during times of mass casualty will come and assist. The actual field hospitals themselves and where they set up was, to my understanding, was more of a federal decision. And I think the fact that the regional council in New York City coordinated a lot of these things, the Office of Emergency Management was also involved. And these are groups that we need to be in communications with ahead of time. We need to know the caregivers and their level of expertise, for example. There are still people in the emergency departments who function who don't know the difference between an EMT and a paramedic and their skill levels and their training. And I think that's all important. When you pair up a person from Jersey with a person from New York City, whose protocols are they going to use, who's going to drive, who knows the area, who doesn't know the area, these types of semantics may seem, but when you get down to the day-to-day functioning, they can become crucial. The fact that people will flock perhaps to the closest hospital, and we try and bring the most stable patients to the farthest hospital and save the closer hospitals for more critical patients as part of the disaster planning. The availability of different types of units out there in terms of rescue medics, in terms of those who are capable of doing decontamination versus those who are doing extrication, amputations, for example, these things need to know ahead of time. The MERV units that can help assist treating patients, the respiratory units that the fire department has that can help with oxygen administration for smoke inhalation and albuterol on these these trucks that can do multiple patients at the same time. Reaching out to the stations in your immediate area and identifying what is available ahead of time and talking to people to facilitate how those interactions, how is it going to start? Who's going to declare the emergency, okay, primarily? Who is in charge initially, the first on scene, but then there's a particular stratification, and maybe that the feds are the primary people to essentially run what can potentially be a medical operational interface, and the administrative, the medical, the operational all have to work together, and I think that's critical.
So sticking with that, vaccination and testing, we talked a little bit about traveling before the panel started, and so I'd like to ask Greg, what are your thoughts on global vaccination and testing strategies, and are we moving in the right direction to open up international travel?
Very, very complicated question. You know, we've been experiencing the last, since probably last summer of 2020, this kind of up, down, right? Do you wear a mask, do you not? You know, what stage are we on of reopening? Oh, now we have to go back to mask wearing in certain situations. All the time now, since, you know, last December, trying to promote vaccinations. So it's this really difficult time, not just here in the United States, globally, where, you know, we're really trying to assess what stages of NPIs, again, we need to be at, you know, as well as lockdowns, closing businesses, et cetera, which hopefully we don't get into again. But what level we have to be at, and that's totally dependent on your disease prevalence, which is also totally dependent on testing, and also obviously influenced by vaccination. So it's a really complicated thing. But one thing that I think we all need to understand, and we're getting a glimpse of it with Delta, and there's another variant coming down the pike called Mu, and they're going to be more in the future. And you remember my nightmare scenarios. That nightmare scenario was a novel virus emerging in the future that had those characteristics. Well, what if a variant of COVID emerged in the future that had some of those characteristics? Less likely, but again, possible. The way these variants are coming and happening are we're leaving these reservoirs of virus around the world. And whenever you leave these reservoirs of virus around the world, they have the ability then to, you know, mutate and cause these variants that then, you know, we know that Delta came, you know, from probably from India. It's hard to say. These other variants are coming from other parts of the world. So this idea that the United States should essentially keep all our vaccine to ourselves and not send it out is the wrong idea, okay? If we're going to get on the other side of this pandemic and get to that vaccine-mediated herd immunity of probably around 80–85%, we're not quite sure, it's got to be on a global scale, because as long as there, I mean, we could do a great job here in the United States, which we're not, but we could, and get ourselves up to that vaccine-mediated herd immunity. But if there's a pocket out there in the world where vaccines just are not accessible and a new variant comes up, who's to say that new variant isn't going to come around and be either more resistant or very resistant or completely resistant to our vaccines, and now we're at stage 1 again. Not exactly, but close to stage 1 again. So my point being, we need to vaccinate. We need to get the world to vaccine-mediated herd immunity. So we need to push vaccine out everywhere.
Thank you. So the next question for all the panelists is, most of you mentioned, or all of you mentioned, about interacting with community partners. So what are some of those community partners that we need to interact with? How do you solicit input from them and make them feel like a real partner in your planning for anything that might happen in your areas? Anybody?
I'll quickly add, I'm sorry. It's developing that symbiotic relationship and making people understand it's a symbiotic relationship. Hospital systems depend on the community and the patients to understand and practice the right things so that they don't surge beyond our capacity. And at the same time, the community depends on hospitals to be there when they need them, right? So it's a really symbiotic relationship, and just getting that out there to your community stakeholders, I think, is important.
Thanks. All right.
I was going to say keeping certain phone numbers right next to your phone can be critical. Public health departments, liaisons for organizations, contractors for supplies, medications. Those are all important things to have readily available.
Thanks, Laura.
I mean, I think it's imperative that you have to have these, relationships with agencies, relationships with community-based organizations, relationships with, intergovernmental agencies in the city and other governmental agencies locally and regionally. Public, private, nonprofit relationships are very important. And I think it's all really important because you want to get your interventions, your messaging, your policies out to these hardest hit communities. So you really have to have these relationships that are already in place when something like this happens. And that is the first step in mitigating, healthcare disparities and social inequities. Just having those relationships in place at the get-go.
And I think it's a combination of what would be considered traditional emergencies, so the Red Crosses, the campus, the community emergency response teams, things like that. But then the non-traditional, what I'll call the social, so the Rotary groups, faith-based organizations, places that exist already in the community that invariably in a crisis, certainly in a pandemic and other large-scale incidents, they want to help. They're looking for something to do. They're looking to contribute, which lends itself sometimes to be wary of spontaneous volunteers and have a plan to be able to manage them because they will come. One of the things we learned early on, donations came fast and furious. We essentially had to set up a warehouse and distribution center because people will bring you everything they think you need, whether you need it or not. We engaged a local group of the Stony Brook Stitchers when there were trouble getting masks. So it was a bunch of retired grandmas in the community who knitted and stitched together thousands and thousands of masks. So it's the traditional things, the traditional places you would go, the Red Crosses of the world, and then those non-traditional organizations that exist through the library, through the PTA, and they all have something to bring to the table, but make sure you can manage them because there will be lots of them.
Thank you. Next question has to do with planning at the local facility level. So I remember a story, and I don't remember the exact disaster, but we were talking about community shelters. And there was a community shelter that had no handicap access. So how are your organizations dealing with handicapped people with limited movement abilities during or before a disaster to make sure that they're safe and they're included in your planning?
I think one of the things is that having people who have these issues be made aware of to local authorities. For example, if a patient's on a home respirator or somebody is on something related to machinery that, for example, the electric company knows about them ahead of time. The identification of people with special needs, the children certainly become an issue. So working with the PTA perhaps to educate ahead of time, to help them develop plans for emergencies, to have a person outside of the area, relative perhaps, be a contact. So should communications go down and they can't communicate in the immediate neighborhood, that they could reach out to someone else and both people would know to contact that person to make sure that people are aware of the other's existence, the other's condition. These certainly become issues when there's an event at a school perhaps where hundreds of parents will converge worried about their child, and then how is the school going to handle that? Also, from the hospital aspect, you talk about the Las Vegas, and you had 90 or so people showing up at the facility with no identification because purses and wallets had been left behind at the scene. How are you going to plan about to coordinate this identification? How are you going to track the patients? How are you going to notify their families?
I mean, I think, you're going to take a look first at your hazard vulnerability analysis and your top threats. And you're going to create drills around them that incorporate these vulnerable populations, drill them to the point of weakness and find out where your weaknesses are, that you need to revise the policy and then train again. And, this all creates muscle memory and fixes hopefully the goal is to fix the issues that arose and all the barriers that arose to being able to effectively accommodate these vulnerable populations. But I think it starts with the HVA and the drills, and then the re-drills and the policy revisions.
I think one thing that oftentimes we don't necessarily think about, it might not be popular to do initially as you're standing up a place to help people, is to think about the demobilization. So oftentimes the space you're using has a normal purpose, whether it's a school or whether it's a building. But just as soon as you mobilize, you have to also be planning on how you're going to get that facility back to its original purpose and when and if you can. And we're actually experiencing that right now with the building that's housing our mass vac site. It's a research building that has been offline for the better part of a year. Same with a shelter. Once you open it, at the same time, have a simultaneous plan to figure out how to close it and how to reacclimate folks back to, their normal, place where they're from. So that's just from a planning perspective.
Mm-hmm. Great. So in the early 90s, there was a system called Hospital Emergency Incident Command System, HICS or HICS, depending on what state you're from, that tried, at least one part of it was getting pre-hospital response agencies and hospitals to speak the same language. And so we started educating hospitals on how to do tabletops and how to implement this command system within their emergency medicine planning. As you look internally toward your own organization's plans, how are you using this system? Are you still using this system? It's evolved over the years, right? So it would be interesting to hear how you're using that and if there's any use internationally.
Well, yeah, I mean, there's variations of that. The incident command system is really a very U.S.-centric thing. It's not used in a lot of the other parts of the world. They use a similar system, most of the other parts of the world. But the incident command system and the hospital version of it is a very good system. The idea is, when you have a disaster, the chaos of disaster, you have to sort of put on an artificial sort of governance system on top of that disaster to bring the chaos back to organization until you can then resolve the disaster and go back to your normal operations. That's what ICS is. It's all about command and control. We do use, a variation of the HICS system, and I think it's very effective. I would say one thing, again, to all the healthcare executives and leaders that you all are. One thing that we found successful in our emergency management, hospital-based emergency management, was the way we structured it. And I would love to go around the room and ask you, where does your hospital emergency management office or person, where does it sit in your sort of org chart of your hospital? Because in many cases, the emergency management, Office of Emergency Management, is out there. It's sort of this piece out here, and it's sort of perceived as, well, that's the place where we throw all this money and all these resources to prepare for something that might never happen. That's that thing. And one thing that we did a while back, about 15 years ago, when I was medical director for emergency management for my medical center, is we took it from out there and we put it under quality assurance. So it actually sits as part of the Department of Quality Assurance, with the understanding that, and we tried to project this, that, a lot of what we do in hospital-based emergency management, not everything, but a lot, is really just improving hospital systems, trying to make the hospital, all the different systems, whether it's lab, it's, ER, to inpatient, it's everything, more efficient, because when that patient surge comes, in all disasters, whether the lights and sirens disasters like a mass casualty incident or they're more of a public health long-term disaster like a pandemic, it all involves patient surge to one degree or another. So the more efficient you can make your hospital operate in everyday processes, the better off and more efficient you're going to be in a disaster. So suddenly that became more of an understanding, okay, this is not that sink that just drains our resources. It's actually helping the everyday operation of the hospital, just simply by putting it as part of quality assurance. And I think that was very successful for our organization.
I think the fact that my experience with the incident command system has been basically pre-hospitally. The time that I was an emergency department chair, I think that it was in the early times, it was all plans, and we were happy to have those plans come along, I think, to give us a tree to start working with and hang our branches on. I think that the interface of that, going back, I have to say in New York City, we had for many years the 911 committee, which was formed voluntarily by hospitals that wanted to be part of the system. And so there was a physician, a nurse, and an administrator from every hospital that came together to develop standards. And then gradually that evolved to include the pre-hospital standards as well, because it made no sense if we had, for example, a pacemaker in the ambulance and the hospital was not familiar with that in the emergency department, or mask trousers pre-hospitally, and they did not have them or were not familiar with them in the emergency department. And so that gave us for many years a way of communicating with each other and trying to all talk the same talk and have the same standards, the same turnaround time for lab work, the same reference books, the same training of staff. And I think the education of staff and the planning is what is crucial here. And I think keeping everybody's responsibilities in a disaster as close to day-to-day operation as possible also helps.
Thank you. Okay. Audience questions?
A year and a half ago, when we were getting into the pandemic, there was a huge problem with testing. I'm looking directly at Larry because I worked for WMC Health in Westchester County. In Valhalla, we were one of the first, along with Stony Brook, to become a suburban provider of testing. There was actual chaos with most of the first responders in New York City because they had nowhere to go for testing. And we just mobilized as best we could. I know Stony Brook did as well. And we learned a lot during that process. Now we're at a point where we're doing things more on a micro level. And I was very heartened to see that the Biden administration today is interested in purchasing the home testing program, which I think is probably the best way to go right now for a pandemic. But the question is, why isn't this being ramped up faster? I know there's some political pieces to it, certainly I think from the perspective of resources, but it just seems to me that when you deploy people back into the office environment, you have children going back to school, you have educators, we need more home testing. Just would like to get your opinion about that. Thank you.
Yeah, thank you for the question. I think that testing has been an evolving situation. Nimble is the word of the day, for sure. But I think with the reliance on, or the expectation that exponential increase in vaccination rates would somehow inversely drive the need for testing. And when we started to see breakthrough cases and we started to see high percentages, not huge percentages, but couple that with the returning workforce, indoor masking in different places, and we were talking about this before the panel. It changes county to county. Out in Suffolk County, there is no indoor masking. There's no vaccine proof required. So I think as all of those MPIs varied and the ability to get testing, the degree, I know you remember early on, we would be waiting for our delivery from Wadsworth for the packages to come, and the National Guards people would be putting swabs in Ziplocs in the parking lot while the line was, wrapped around. It was everyone's best effort, but the coordination to do that and the distribution of where those resources went, I think, was the biggest challenge. Fast forward to now, and I agree wholeheartedly, the decentralized approach, making it more available to support K-12, to support those who have not leveraged remote work and to that extent. But I think we need to continue to test as much as we can as we continue to push for vaccination in all aspects. So I agree with you, and I'm glad to be with you from the beginning on that. We were suffering north and south, that's for sure.
I think the one push for test and trace to keep their system up and running and have their pods, they've kind of infiltrated with pods and they have their mobile testing sites, is the trace part of it. They've really done a phenomenal job of being able to, there's that person who's infected and obviously needs to isolate, but then who else needs to quarantine? And they've done a good job of finding those contacts and getting a hold of them and getting them to quarantine. And I think that's the one thing you lose with the home testing is that tracing and quarantining part of it.
So earlier, we spoke about learning from past experience. In regards to COVID, it seems that as an industry, healthcare in general, that we were caught off guard. There were times we were running out of PPE, running short on masks. We were happy at times that the public was bringing us masks, to the hospitals, which was something that has never ever really happened before. But I recall during Ebola, we trained staff, we trained hospital staff. We had an Ebola wing in the hospital. We were very prepared, an Ebola ambulance. So my question is, was there a miscommunication somewhere along the line, either from federal to local? How was it that we were able to be so caught off guard in regards to supply chain and those things? So it was, like almost embarrassing that we didn't have enough PPE to even, give to our workers. So I guess that's my question. And just what can we do to ensure, what is being done to ensure that something like this doesn't happen again in regards to learning from, this experience?
I can maybe take a quick stab at that. Concerning the PPE, my opinion, we missed it. We've all done preparedness drills. I did tabletop drills on pandemic influenza, at the time, 10 years prior to COVID, and then since then, and we identified a lot of things. We identified the fact that, we need a lot of ventilators, we need to source them somewhere, we probably need alternate care sites. We made relationships with colleges around us to use their dorms for alternate care sites. We realized that probably in a real bad one, we're gonna have to turn the entire hospital into one big ICU and push out the elective care and preventative care out again into these alternate care sites. We missed the PPE. I think that's just my understanding and my experience is we missed it. We didn't predict that. But this is the idea of, again, the disaster cycle. 4 simple stages: mitigation, preparedness, response, and recovery. So in the after-action analysis of this global once-in-a-100-year pandemic, there's going to be a lot of things looked at, and that's one of them. And if we do it the right way, because we're always going to miss stuff. I mean, you're going to miss things. But if we do it the right way, we're not going to miss it next time. So it's really about learning the lessons this time that need to be learned.
When I was coming up in cybersecurity events were local to an organization. You had a data breach or whatever. In the last couple of years, we've seen multiple hospitals shut down and have to divert patients to other hospitals, creating the patient surge for other regional hospitals, while, Scripps and UHS and all these folks that have gone through cyber events. And I'm curious to understand, how have your disaster preparedness plans had to change for these sort of man-made cyber events at a neighboring hospital, creating diversion towards yours, if any?
So essentially, that's a great question. The ability to very quickly switch from computer to paper, as basic as that means, pull yourself completely off of your, your medical record and back into the paper and pen world, both internally and then your ability to leverage that into your surge plan, whether it's within the health system or within your partner systems, is something I think we sort of forgot about. Everything is cloud-based, everything, right? But the second that you either can't get into your system or your system's been compromised, you have a bifurcated issue. You have to manage the cyber incident, so you have in leveraging your insurance provider and maybe negotiating with the cyber actor and trying to get access back to your data, but at the same time, your network and your day-to-day job still has to happen. So speaking personally for us, we've gone back to the basics and having the ability just when the flip gets switched on us, we go back to what we know best, and that's paper and pen. It's not a perfect system by any means at all, but have a backup to your backup is what I would say.
So one of the things that I've seen, and maybe we've crippled some of our providers or clinical providers by becoming so technologically dependent, as I've heard the comment when systems have gone down, it's, oh, the computer's down, I can't take care of my patient.
Yep.
So, have we crippled our providers in that aspect? Because going back to pen and paper, maybe that's something we should be drilling. I don't know.
That's why you
Yeah,
need
no,
more
Something
of us.
we drill.
Yeah.
You need more of us old guys that grew up that way.
Right.
That's right. Over here.
I shared a dinner with a board member of a small rural hospital in Wisconsin who told me a story of how his hospital was hit by a ransomware attack and they all switched to paper, and it lasted several days until they finally gave in and they paid. So my question is, what is the threshold of an event in which it is our government's responsibility to be providing protections? And are local healthcare organizations working together to create these national level protections?
Who would like to take that one? That's a good question, but it's difficult.
Well, I'll take the first stab. There's, there are, the way the systems developed is to have scalability. So if it's working properly, the system should be that a small-scale disaster, if it's, exceeds local capacities, goes to regional, goes to state, goes to federal, et cetera. And we keep on kind of overlying this scalability piece. I don't think there's any one threshold or one trigger of when to do that, but it should be sort of inherent in the process. And the way it's going to be more muscle memory to do that sort of scalable process is by practicing it more and more. I like to say better the planning than the plan. It's okay to have a plan, but a plan will get you through the first 10% of a disaster. Then the disaster's going to turn left, turn right, and the plan's going to keep on going straight ahead. It's the planning process that's going to allow you to pivot as the crisis pivots. The system's sort of set up with that scalability, if that's what you're asking. It doesn't always work the right way or well, but it's sort of set up. One last quick thing, if you want to look at cyber attacks on healthcare systems, look at what happened to the Irish healthcare system in the last few months. They were decimated by a cyber attack, still have ramifications from it, and had to spend literally a couple months in that sort of hindered sort of practice because all sorts of systems came down. The PACS radiology system, a lot of the EMRs, et cetera, came down. It was rough.
I would just add very quickly to that while there are federal resources, certainly for investigatory perspective, FBI, DHS, CISA, things like that, if I was your risk advisor, I'd be telling you or that organization, be prepared to be entirely self-sufficient. You need to have a cyber infrastructure as though you were acting on your own.
We all know COVID is it's a global disaster, but just have a few questions regarding what Dr. Greg was saying earlier. My question is, we all know right now UN is putting in a lot of money to help solve the vaccine issues, and WHO is doing the same thing. My question to you, to the system, is what are you guys doing to support the disaster that's going on in third world country? Are you guys leaving the whole entire issue for government only, or do you guys have initiative to kind of support healthcare system in other countries to solve these issues?
Well, if you're looking at my organization, World Association for Disaster Emergency Medicine, we are not a response entity. We're more a collection, essentially, of educators and specialists and practitioners of disaster and emergency medicine all coming together to do things that are going to better the world's education and response to disasters. But we don't actually do interventions. We don't respond ourselves. We don't implement policies. WHO, however, is an organization that is more on that kind of operational level, and we do work closely with WHO. But as a general overarching statement, often what happens when we try to increase global standard of care in healthcare in general, but certainly in disaster response, we have to understand the limitations we're working under. And that is, if you compare the National Disaster Medical System in the United States with WHO or what's going on internationally, you'll realize that the one thing that's lacking on the international level is enforceability. We can enforce it here in the United States because we can say that, and this happens in disasters that become sort of federalized disasters, we can say that, no, you can't play in this disaster now because unless you're credentialed by us and have gone through all the processes to be credentialed and be deployable on a team, you've got the education, you've got the credentialing, et cetera. We can enforce a degree of enforceability for that. On the international level, we can't do that. However, one thing that WHO did in response really after the 2010 Haiti earthquake was to create a system called the Emergency Medical Teams, or EMTs. They chose a wrong term, I know, but this is the other EMT. It used to be Foreign Medical Teams, FMTs, but now they're EMTs. Anyway, so, and it's really kind of a unique system in that you have to have, and they're fairly strict criteria for international disaster teams to be designated and fulfill, to be credentialed an EMT level 1, 2, or 3, which varies based on surgical capability or not. But to achieve that accreditation, you have to, it's a rather rigorous process to go through that. Then you're credentialed. Now, it's still not to say that other teams that are not credentialed, which might have questionable practices, won't come and respond to the disaster. But what's happening more and more internationally is it's almost like peer pressure. And now also some countries are starting to look at it and say, okay, if you don't have an EMT designation from the WHO, then you're not coming to my country to help with this disaster. Will we ever get to full enforceability? No, probably not. But we are attempting on the international level to try to raise that standard of care. It's a very, very complicated thing, but there is activity in that direction. There's an effort in that direction to increase the standard of care in international disaster response. And to finalize real quickly, the biggest thing in my mind to doing that, to building disaster resiliency internationally, is to build local infrastructure, local capacity. We were really fearing 2020's hurricane season in the Caribbean in the midst of COVID, because we felt that, if another Maria or Irma happens in the Caribbean, are we going to actually have the teams globally to be able to deploy there and help, because they're very reliant on international help. We were fearing something like that. 2020, thank you climate change, was the most active hurricane season in the history that we've been measuring them. But luckily, we didn't have one very large impact on one island nation. So we sort of avoided that bullet in 2020. We're so far getting our way through 2021. We've had a lot of devastating disasters, I know, but again, we're sort of working our way through. But it's that sort of thing that leads us to believe that building local infrastructure and capacity is really a good way to go to increase the capabilities of international disaster response.
The COVID-19 pandemic affected everybody. So I was involved very much in the response as well, in the local facility level. So my question to the panel is there, I heard you mention something about the global incident command system. So in the hospitals, in New York City, there are different hospitals and agencies, like federal-run hospitals, city hospitals, state hospitals. Is there any effort or is there any barriers in coordinating everybody in terms of having a hospital command center so that we are more unified in terms of our responses for the next pandemic or next disaster?
Yeah, sure. So I, as I said, work for New York City Health and Hospitals as the emergency management lead. And we, at all of our facilities, each of the facilities does have an incident management team. And what that is an overarching incident commander that runs the event, the command staff, the liaison officer, the safety officer, the med tech specialist under them who are advising that person. And then there's, your section leaders, your operations, your logistics, ancillary clinical, your finance, and then all the units under them supporting them. So every single one of our 11 acute care facilities, our 5 post-acutes, and our Gotham, we have 70 community-based healthcare centers, all have this structure in place, and they all communicate with our central office emergency management. We have gone from the central office overarching emergency management structure, that same IMT structure, to a little bit different, because at central office, we're really not boots on the ground, we're really more policy and decision makers. So we've kind of, after this past wave, shifted to a MAC group, which is a multi-agency coordination group that informs an emergency operations center. So there's the thinkers and kind of the doers, and then it pushes out to all the sites, and then they actually are the boots on the ground that make things happen. So that's how it works in our organization, and that works in other big organizations throughout the city, throughout the region, throughout the country, and we all can talk in this same language and communicate with each other. And even when one of these different agencies comes to my institution, they can be integrated into this common structure. So that's the beauty of this, is that it's a common structure, a common language. It can be expanded, contracted, and used universally. I'm Italian, I use my hands.
If I got a question, in terms of, and your comfort level here, concerning predictive analytics, if you look back at our last few disasters, but then taking into account the COVID experience, if you will, and where resources and the supply chain kind of took us, do you think that we are utilizing the past experience on a more predictive analytic basis, taking into account the electronic medical record and where patients wound up and their conditions, and globally populations, say within the city of New York as an example, and some of the concentration of various disease management issues, COPD, things like that. Do you think that we have the ability to utilize predictive analytics a little better in terms of understanding where these populations lie and where the greater emphasis on resources may need to be employed in the event of another COVID, in the event of another natural disaster?
I think one of the biggest challenges is the fiefdoms that are created by virtue of bureaucracy. And that's just the reality of it. That may seem like a political statement, but it's definitely not. The information is there, and if everyone were willing, either through acquiescence or a little bit more force, to be able to share it, I think there is a world of benefit that we would get out of it. I'm a big fan of big data and using the data, but you have to share it, and having it within one health system or within one governmental entity is not it's not helpful for anybody. So,
has the regional health information organizations been a positive aspect to the emergency management component?
I mean, I think Haney's, Greater New York, like there are great organizations that are there. They can only share the information that they're given, and they have a lot of it, but I know that there's a ton more out there that can help a lot of people that's just not being shared.
My question comes into, what do you think the most appropriate way to fund this resilience would be, and what would be the appropriate metrics to ensure that the organizations involved in response are actually ready when called upon? This might be a hard one right before lunch.
The question was the metrics to use in a response to make sure you're ready. Is that what I understood?
How it's funded, and then how to ensure that the money actually goes to being spent in the right way, so when these rare events occur, we're actually ready. And I think back to this, like particular COVID, we've had years and billions of dollars spent on all sorts of preparedness, but it actually went to the wrong things. And I also think to my experience with hospital and operations, when, we're always trying to squeeze out excess capacity, we're not looking, if it's a 1-year event, maybe we're prepared, but if it's a 5-10-year event, that gets squeezed pretty easily. I know of one hospital that had 6 months of PPE in 2019, and the consultants told them to get rid of it. That wasn't so great in 2020. And as a former consultant, I never made that recommendation, but I could have. That wouldn't have been an unusual recommendation. So how do hospitals and other organizations like that, especially privately operated organizations, how do we as a society fund them to provide this resilience but then also make sure that they actually use it to spend money. They use it for the resources that when they're prepared when these rare events occur.
I mean, I think it starts at the local level, and, you know, as emergency management and emergency managers, you know, we don't make money for the hospitals. We actually cost them money, as that's how they look at it. But in all reality, we save them money, because if we're well prepared, then there's less damage. There's, you know, we mitigate the bleeding of the money, to say, during the disasters. But in blue skies, we're not a money-making entity. So I think that, you know, really drilling down on the local hazards, so your hazard vulnerability analysis, and knowing what your biggest hazards are, really honing in on them. And locally, you would need to, you know, drill on them, find your weaknesses, adjust your plans, re-drill, and then you need to take all of that information and talk to your local Department of Health, your state Department of Health, and then all the way up to ASPR, where, you know, the money kind of starts, because a lot of these public funds go to public health and don't go to hospitals. And I think, you know, you have to get the ear of your government, local agencies, up to, you know, the other agencies that really tell them that this is where we need the funds. So it starts locally, but then it ends up being a countrywide issue.
Very good. I want to thank everybody. I want to thank especially the panelists for your time, energy, and expertise, and for being here this morning. And I also want to thank the attendees for being here. And I'm going to make an unashamedly plug for everybody to join Health Leaders of New York, if you are not already a member. And if you are a member, to please consider becoming a fellow. And any of us that are members or fellows would be happy to talk to you about the process. And enjoy the rest of your afternoon.